In this section, we'll cover reproductive endocrine physiology, and we'll look at both the male and the female hypothalamic pituitary gonadal axis. So first, let's consider the male HPG axis. So again, the axis is driven from the the hypothalamus with the release of GnRH, or gonadotropin releasing hormone, which works on the pituitary to release LH and FSH, and then these two hormones work on the testes to either release testosterone or enhance spermatogenesis. So again, if you recall from the introductory section, FSH and LH are working on G protein coupled receptors by activating the GS subunit and to increase the CAMP levels, and LH works on the Leydig cells, which then releases testosterone. FSH, on the other hand, works on the Sertoli cells and to enhance spermatogenesis. There is negative feedback regulation at all levels, and in the case of FSH, or specifically from the Sertoli cells, there is also another hormone that's released called inhibin, which then feeds back to the anterior pituitary to suppress FSH. So again, the axis is driven by GnRH, which then releases LH-FSH from the pituitary, which then releases testosterone from the testes. The maturation of the HPG axis occurs at the time of puberty, as shown in this slide, where there is pulsatile nighttime secretion of gonadotropins that primes the system and then ultimately results in a constant burst of LH and FSH. And they progressively continue to increase during the course of adulthood. The peak onset of testosterone is occurring between 25 and about 40 years of age, following which the levels of testosterone progressively continue to decline. And then at the time of senescence, there is both a decrease in testosterone and spermatogenesis and a consequent increase in gonadotropins as a result of negative feedback, and that would be the situation of primary hypogonadism. Testosterone is again a classical steroid hormone. It works by binding to the steroid receptor. And in this slide is shown schematically the various effects of testosterone. So testosterone is carried in the bloodstream by binding to sex hormone binding globulin or just albumin, and then once it gets into the target cell, gets reduced to another important hormone called DHT, or dihydrotestosterone, and the very important enzyme that ensures this reduction is called 5-alpha reductase. And this is another rate-limiting enzyme which we'll cover in the later part of this section, because the dysregulation of this enzyme leads to ambiguous genitalia in the males as well. So again, testosterone can work as testosterone or as dihydrotestosterone. And dihydrotestosterone's effects are primarily involved in the development of primary sexual characteristics, whereas testosterone is involved in the development of secondary sexual characteristics, such as the growth of the facial and pubic hair, increased muscle mass, increase in spermatogenesis, increase in libido, and so on. So this is a question that highlights the issues of feedback regulation. So this is a 55-year-old man who has had decreasing interest in sex over the last 2 years, impotence for the last 6 months. He's had frequent headaches. An examination shows bitemporal visual field defects, sparse facial and pubic hair, and testicular atrophy. MRI shows a 3-centimeter tumor, and which of the following sets of hormone concentrations is most likely? So first of all, it's important to recognize in your mind, before looking at the answer, what type of hypogonadism this is. So first of all, this is hypogonadism because he's now talking about a decrease in libido, and importantly, this decrease is associated with bitemporal visual field defects, bitemporal hemianopsia. That's what they're describing here. And you know that that's likely the case because the MRI shows, in fact, a pituitary tumor. So this is most likely secondary hypogonadism because of this constellation of symptoms. So if it's secondary hypogonadism, then the defect is coming from the pituitary. So likely this patient is going to be having low LH, which is driving the low testosterone. So the correct answer to this would be A, as opposed to D, which is primary hypogonadism. So D is showing you low testosterone, but the low testosterone is feeding back to the pituitary to increase LH, and that's the case of primary hypogonadism. Whereas A is low LH, which is driving the low testosterone, and that's secondary hypogonadism. Here's another question sort of highlighting the feedback regulation. So this is a question that's showing the pathway from the hypothalamus to the testes, and there are X and Y as the unknowns. During an experimental study of the male reproductive function, researcher administers various neutralizing antibodies to male experimental animals in order to map the regulatory factors. So they tell you in this question that X represents testosterone, and they want to know which hormone represents Y. So the correct answer to this would be testosterone, because number one, the Leydig cells, as I told you earlier, produces testosterone, and testosterone has negative feedback effects on both the anterior pituitary and the hypothalamus. And also, it has negative feedback effects, or I should say positive feedback effects, on the Sertoli cells, because testosterone that's released from the Leydig cells will actually stimulate spermatogenesis in the Sertoli cells. Sertoli cells produce the hormone inhibin, which then feeds back to the anterior pituitary. So again, the answer is E, testosterone. So now let's move on to the female HPG axis. So just like in the testes, there are two cell types in the ovary. There is the theca cells and the granulosa cells. And again, just like in the testes, the regulation is driven by the HPG axis, again coming from GnRH from the hypothalamus, LH-FSH from the pituitary, and then working on the specific cell types in the ovary. So LH binds to the theca cells and to the LH receptor, again, which is a GS subunit activating CAMP, which then triggers the pathway from cholesterol to testosterone. Testosterone then diffuses into the granulosa cells and gets converted to estrogen by the activity of aromatase. So aromatase is the enzyme that converts testosterone to estradiol, and the estradiol then in turn gets diffused into the bloodstream and gets carried to its various sites of action. FSH is working primarily in the granulosa cells to support follicular development, and also helps convert testosterone to estradiol by upregulating aromatase. So again, LH works on the theca cells to produce testosterone. FSH acts on the granulosa cells. It supports follicular development, but also upregulates aromatase to convert testosterone to estradiol. The activity of all these hormones are orchestrated to result in the menstrual cycle. So in this slide is depicted in schematic form the various events that happen in the menstrual cycle. So in the first phase of the menstrual cycle, the first 14 days of the 28-day cycle is considered the follicular phase, which is largely driven by estrogen. So this is the phase where the follicles are being matured and the follicles are getting ready and ready for ovulation. In the mid-cycle, which is approximately around day 14 of the 28-day cycle, there is a surge of LH, which then results in a surge of the estradiol, which then ultimately results in the ovulation process. Once ovulation occurs, the subsequent stages is considered to be the luteal phase. The luteal phase is largely driven by progesterone, and it is the stage where the endometrium and the uterus is being prepared for pregnancy. If pregnancy does not occur, then the prepared endometrium sloughs off, and the sloughing off ultimately results in the menstrual period. And then the whole cycle starts all over again. So this is a question that tries to highlight the menstrual cycle issues. So serum samples from a normal woman with a history of a 28-day cycle shows a peak in the serum concentration of estradiol over the past 12 hours. No progesterone is detectable. So they want to know within the next 3 days, which of the following is expected to occur. So the correct answer to this question is D, ovulation, because as I said before, the key events that precede ovulation is a surge of estradiol, then a surge of the LH, which then releases the egg to be ovulated. And then once ovulation happens, the second phase is the luteal phase, which is driven largely by progesterone. And here they're telling you that no progesterone is detectable, and therefore clearly you're not in the luteal phase, and therefore you cannot be in the regression of the corpus luteum or onset of menstruation for that matter. So the correct answer here is D. Here's another example of negative feedback. So an otherwise healthy 48-year-old woman comes to the physician because of a change in her menstrual pattern. Her last normal menstrual period was 4 months ago, and she noticed scan staining 3 weeks ago. Her history is otherwise unremarkable. Physical exam shows vaginal dryness. Laboratory evaluation is most likely to show which of the following. So this lady clearly has symptoms of menopause. So the clues that tells you that is her age, because the mean age of menopause is around 50 to 52. So 48 is around the perimenopausal period. Her last menstrual period was 4 months ago. She's got scan staining, so she's certainly in the perimenopausal period. But the exam clearly shows you that she has low estrogen. So vaginal dryness or vaginal atrophy is a physical finding of low estrogen status. And because this is in the menopausal situation, there is classical negative feedback. So low estrogen will then stimulate the pituitary by negative feedback to increase LH and FSH. So this lady is going to have an increased FSH rather than a decrease in FSH. So the correct answer is D, increased FSH. So when the menstrual period is not functioning properly, the dysregulation of that process is called amenorrhea. And the workup is really important to understand because several questions are centered around whether the problem is primary or whether the problem is secondary, just like we've been talking about with other systems. So it's important to separate out the two. So primary amenorrhea by definition means that the girl is at least 16 years old and has never had a menstrual period, or she's 14 years old and has had no secondary sexual features, or there's at least a 2-year delay between the secondary features and the menses. So in other words, primary amenorrhea refers to a process where there has really been no menses in the first place. The first question you want to ask once you've made the diagnosis of primary amenorrhea based on the clinical picture is to look for the physical finding of whether or not there is a uterus. So if there is no uterus, then the problem is likely to be a congenital anomaly or a congenital problem. The most common of that is something called androgen insensitivity syndrome or testicular feminization. If there is normal uterus and normal breast development, then likely the cause may be lying in the secondary causes. And so follow-up of the secondary amenorrhea workup may be required. Then the second half of this slide, on the right side, is the workup for secondary amenorrhea. So the most common cause of secondary amenorrhea is pregnancy. And so you would always want to get a pregnancy test first to work up secondary amenorrhea before you do anything else. Another common cause of secondary amenorrhea is hyperprolactinemia. And therefore, right after you get a pregnancy test, you should also get a serum prolactin level. If their prolactin level is elevated, then the next step in the process would be to get a pituitary MRI and then to treat medically the hyperprolactinemia. But oftentimes, the situation will be that the woman has secondary amenorrhea because she's not pregnant and because she's doesn't have hyperprolactinemia, but it's something else. So after these two tests, the third test to get would be to do a progesterone withdrawal test. What this test is the administration of Provera, 10 milligrams, and then observing if there's bleeding 5 days later. Normal physiological response is bleeding that happens in the context of progesterone. If that happens, the diagnosis is likely PCOS, which suggests also that the uterus has enough exposure to estrogen. The abnormal response would be no bleeding, and in this case, it would suggest that the estrogen in the uterus is not sufficient. In these situations, you can obtain the FSH levels. If the FSH levels are high, it indicates the diagnosis of premature ovarian failure. But if the FSH levels are low, then it could be a situation such as Kallmann syndrome, especially due to a lack of GnRH. And in these situations, these patients would have additional manifestations such as anosmia or an inability to smell. We will do a few questions to try to understand this concept better. So this is a 14-year-old girl who was brought to the physician's office by her mother, who is concerned that the girl has not begun to menstruate. Physical exam shows normal breast development, no pubic hair, normal female external genitalia, bilateral inguinal hernias, a vagina that ends in a blind pouch, and no palpable uterus. Ultrasound exam confirms the absence of internal female genitalia. The underlying problem is related to which of the following? So clearly, the first thing to understand here is whether this is primary or secondary amenorrhea. So this is a 14-year-old girl who has not begun to menstruate. So that is, by definition, primary amenorrhea. The second thing you want to ask in the situation of primary amenorrhea is this girl have a uterus or not? And the physical exam clearly shows that she doesn't have a uterus. So this then tells you that you're dealing likely with a congenital anomaly or a congenital problem. And the most common of these congenital anomalies is something called androgen insensitivity syndrome or testicular feminization syndrome, and that is likely due to defective androgen receptors, or A. So this physical exam is also illustrative of many other features of androgen insensitivity syndrome, such as the normal breast development, the lack of a vagina that ends in a blind pouch, and bilateral inguinal hernias, which are actually undescended testes. So the underlying defect again here is defective androgen receptors, and this girl is really genotypically a male. So the genotype is XY, but because there is no androgen receptors, all that extra testosterone gets converted to estradiol, and the estradiol then results in the manifestation of normal breast development, no pubic hair, and the rest of the other physical findings. So it's important to work the problem by looking at what the condition is, which again is primary or secondary, and then once you identify it's primary, then you want to look for the key physical features, in this case particularly the lack of the uterus. Let's do another one to try to understand this a little bit better. So this is a 30-year-old woman who is gravida 1, para 1, so she's clearly had a pregnancy successfully before. She comes to the physician for an infertility evaluation. She's had amenorrhea for the past year. So clearly this woman is not having primary amenorrhea, but in fact secondary amenorrhea. So first sentence you can pretty much know whether you're dealing with primary or secondary. Menarche occurred at age 12, pubertal development was normal, menstrual periods were fine, and then became erratic after the delivery of her child 4 years ago. Examination shows normal exam except for the atrophy of the vaginal wall. Again, remember I told you that if you see atrophy of the vaginal wall or dryness of the vaginal wall, it's indicative of low estrogen. So they did the appropriate things, which is number one, which is to do the pregnancy test, because that's always the number one test. Second test is a prolactin, which they should have done, but you can assume that's normal. And then the third one is to give a trial of progesterone to do the progesterone withdrawal test. And when they did that, progesterone did not induce menstruation. So which of the following is the most likely diagnosis? So if you put everything together, the most likely diagnosis in this case is option E, which is premature ovarian failure. Because number one, this is secondary amenorrhea. She is not pregnant, she's got normal prolactin, and she doesn't have a normal response to progesterone. If she did have a normal response to progesterone, which is induction of bleeding, then likely the diagnosis may have been option D, which is polycystic ovarian syndrome. But since she did not bleed, the answer is E, which is premature ovarian failure. We'll do another one. 16-year-old girl who's being evaluated because she has not yet had a menstrual period. So that's, again, by definition, primary amenorrhea. She is of short stature, only 4 feet 10 inches, and the weight is 42 kilograms. Breast development is standard stage 1 of 5. Pubic hair growth is standard stage 2 of 5, and she has a low hairline. A cervix is seen on pelvic exam. Laboratory studies show an increase in serum FSH. Serum TSH is normal, serum prolactin is normal, so which of the following is the diagnosis here? So I think it's pretty clear that with a lot of the phenotypical manifestations, what the diagnosis is. So first of all, she has primary amenorrhea, she's got short stature, she's got very immature breast development at least for a 16-year-old girl, and she has a low hairline, multiple pigmented nevi. All these things suggest that she has Turner syndrome. So that's gonadal dysgenesis, or 45XO, which is the genotype, and that's Turner syndrome. So let's talk a little bit about sex determination in both females and males to conclude the reproductive endocrine section. So first of all, during the process of embryogenesis, for the first 8 weeks or so, there is undifferentiation of the sex. In other words, the default sex is female because both male and female structures are present. It is the absence of the testosterone where the Wolffian ducts, which are the precursors of the male genital tracts, regress. Upper ends of the Mullerian ducts will differentiate into the fallopian tubes, and the lower end of the Mullerian ducts fuse to form the uterus, cervix, and the upper vagina. So again, it's the Mullerian ducts that gives rise to the female structures, and the Wolffian ducts gives rise to the male structures. And it is the absence of testosterone that ultimately regresses the Wolffian ducts, and then the Mullerian structures continue to progress to form the female internal genitalia. In the male, it's a little bit different. The Y chromosome actually has something called the SRY antigen, which then triggers the undifferentiated gonad to start forming more of a male-specific gonad, where you have both now the Sertoli and the Leydig cells, which are part of the testes. Again, the Sertoli cells produce FSH, but they also produce in embryogenesis another very important hormone called MIF, or Mullerian inhibiting factor, which is really important for the regression of the Mullerian ducts. So remember, I told you in the previous slide that undifferentiated gonads have both male and the female structures. So if you want to develop as a male, the SRY antigen triggers the Sertoli cells to release MIF, and MIF, which is Mullerian inhibiting factor, causes the regression of the Mullerian structures. The Leydig cells produce testosterone, which then allows the Wolffian ducts to mature and develop and differentiate into the male internal genitalia, which includes the vas deferens, seminal vesicles, and the epididymis. Testosterone gets reduced to DHT by the enzyme 5-alpha reductase, and DHT is the enzyme that's the hormone responsible for the maturation of the primary sexual features, such as the penis and the scrotum. So as you would imagine, the absence of 5-alpha reductase can lead to several problems with sexual differentiation, and in fact, 5-alpha reductase deficiency is the most common cause of male ambiguous genitalia. And if you recall, the most common cause of female ambiguous genitalia is 21-alpha hydroxylase deficiency. So in the case of males, the absence of 5-alpha reductase can lead to this situation where the male ambiguous genitalia can occur. So in this case, patients have a small phallus and undescended testes. So testosterone, remember, again, is important for the maintenance of the Wolffian ducts. And testosterone requires the presence of the testosterone receptors for them to work properly. And in the absence of testosterone receptors or defective testosterone receptors, you get the situation that we talked about earlier called testicular feminization or androgen insensitivity syndrome. And in this case, the genotype again is XY, but the phenotype is a female because they don't really have testosterone action, and all of that extra testosterone gets converted to estradiol by the enzyme aromatase. And in this case, they present with primary amenorrhea with no uterus and undescended testes. So this is a question that talks about how sexual differentiation can be perturbed. So a male genetic newborn has fully developed male sexual ducts and recognizable fallopian tubes. Which of the following processes was most likely disturbed during the embryonic period? So again, as you can see from this question, this male newborn has both male and female internal genitalia. And if you recall again from the previous slide, the Sertoli cells during embryogenesis produces a hormone called MIF or MIS, Mullerian inhibiting substance, that is very important for the regression of the Mullerian structures. And clearly, as you can see, the presence of the fallopian tubes indicates that that particular hormone did not get produced properly. So the correct answer to this question is B. There was a disturbance in the production of MIS by the embryonic testes. So this concludes the reproductive endocrine section. So this concludes the reproductive endocrine section. So this concludes